Hello and welcome to Cynosure University. I'm Barb D'Agostino, and today we're joined by Dr. Michael A. Picos, oral maxillofacial surgeon. Dr. Picos is founder and CEO of the Picos Institute. Since 1990, he's been teaching advanced bone and soft tissue grafting courses with alumni that now number more than 4,300 from 50 states and 43 countries. Dr. Picos maintains a private practice, which is limited exclusively to implant surgery in Palm Harbor, Florida. Before we get started, just a few housekeeping items to share with you. All attendees will be muted for the duration of the event. We encourage you to submit your questions through the Q&A feature located on your dashboard. Later, during our Q&A session, we hope to get to all of your questions, but if we run out of time, an Element Cynosure representative will reach out to you within the next few days. Let's begin today's discussion. Welcome to the call, Dr. Picos.
Thank you. It's a pleasure to be here. I very much am honored to have this opportunity to share some of my clinical experiences with using radiosurgery over these years now. And I'm eager to share some clinical cases and, of course, answer some questions at the end of my talk. So my topic is, as you see here, clinical application of this particular technology. And I will say that there's certain paradigm shifts that occur over one's career. And for sure that the use of this technology from the beginning was in and of itself a bit of a paradigm shift for me because although we have use of electrocautery, true electrocautery in our residency, using radiosurgery as being a different technology really allowed me to become more versatile with the use of it, as I'll explain more in detail. So that said, I'm going to just begin with a few items with regard to disclosure, if you will, a little bit about myself, but most importantly, that this technology for me I've used from the beginning, from 1983, the first year of my private practice. So the team that we have now is an excellent one. Two surgeons with me, both Ken Anderson and Jason Blundell, along with our daughter Lindsay Rosati, is a periodontist, and Phil Hedger, prosthodontist. This is the team that we have. We're adding our son, another periodontist, and still another oral surgeon within the next month or so. So our team is growing. And we represent a true multidisciplinary group practice, if you will, here in Tampa Bay. This is the 30th year anniversary of my institute, and I'm very proud of the fact that we've been able to continue what we're doing over this time frame. As Barb mentioned, I have alumni from all 50 states and 43 countries. And as a result, I'm able to share my clinical knowledge with all of my colleagues from throughout the world. And specifically with the Element technology, I can tell you it's been a real boon to my practice, as I'll explain more. But it's through the venue of my institute that I can share what I do on a day-to-day basis and continue to do so, by the way. My work is focused in one arena for the past 25 of my almost 37 years of practice, and that is implant-based surgical reconstruction. The continuum I have at my institute is, as you see here as well, and it's based on, again, the work that I have compiled over all these years. So very important to know that I wear two caps, a clinical one and an educator one, and I enjoy both of them equally well. So online, we went just this past week, and very exciting because part of the institute now is going virtual, and certainly COVID more or less pushed me over the edge to begin to do this. And our first course was launched last Wednesday. And as you see here, it's on sinus grafting for implant reconstruction. And during this type of surgery, I also will highlight and show indications for the Element technology, the radiosurgery technology in of itself. So again, this is available to everybody. And also in the book that I published, was published this past August by Quintessence, there's a specific section on the use of the Element radiosurgery, but also clinical applications throughout the book, as you will see. And finally, just a quick plug with regard to an upcoming webinar, I should say symposium, that we have yearly, and this will also be at the Ritz-Carlton in Orlando, Florida. As you see, we have master clinicians from all over the world that will be sharing their clinical experiences on hard and soft tissue grafting for optimal implant reconstruction. And final disclaimer here, so important in this digital age of high technology, we can grow bone, grow soft tissue at the push of a button, and that's not happening here. And also, none of these images have been altered or manipulated in any way, and most importantly, these images are of my own cases. So let's get right into the meat of this particular webinar. And I will tell you, this is the outline that I'd like to follow, but it won't do justice in the time frame that I will share with you here, in which I have time rather to share with you, and that is because there are so many important nuances that apply to this particular technology. But I will do my best to give you a good overview of what things are all about for us here at the Institute, and most importantly in my private practice, because I'm still active 4 days a week, and I very much enjoy what I do. I have great passion for both the clinical realm and the teaching realm. So as you see here, 1983 is where it all began for me in private practice, and from day one, the original Element units I still have, believe it or not. They work extremely well. Maintenance on them is almost zero. And those are the original units. Of course, they've morphed into what we have today. The present Surgitron units are just outstanding for so many reasons. But as you're seeing now a series of videos, kind of representative a little bit at least of what I do on a day-to-day basis with regard to application, direct clinical application of this technology. Just a few examples, not even to represent the entire spectrum for sure. But let's look first at some advantages of radio frequencies, radiosurgery. This RF radiosurgery is very specific because of the frequency that it works at, which is 4.0 megahertz, which minimizes heat dissipation. That's very important. And as a result, you see the clinical benefits on the right. I don't need to name all of them, but I will more or less reference them throughout this discussion. And enhanced healing is a big one, and minimizing scar tissue formation. And you might think, wow, how important is that in the mouth? Well, it is important, certainly in the aesthetic zone in particular. And I know Joe Niamtu did an outstanding job with his presentation on radiosurgery. His work being, of course, cosmetic based completely, meaning of the face, head, neck area. Joe's a great friend and colleague, and just an outstanding master clinician at what he does. And he has certainly mastered the art and science, if you will, of using radiosurgery in his practice. So just a few quick words with regard to, again, some science. It's important to have a little basis for why we use this technology. And that as a result of this 4 megahertz radio signal, a very fine kind of what's termed more or less a micro smooth incision can be made without really any pressure to speak of. It's just a light brush stroke that we can use against soft tissue, for example, as we use the little needle point that I'll show you how I'm able to utilize that for periosteal release and related applications. But we can cut with coag, and we can just do coag. So there's different waveforms is what I'm more or less suggesting. And as you see here, again, what's termed a fully rectified filtered waveform applies to the equivalent of using a scalpel blade. In other words, a cutting mode only. And then the fully rectified waveform is consistent with incision and concurrent coagulation, if you will. And thirdly would be what's termed a partially rectified waveform, fancy name for basically saying coagulation. It's strictly used in the coag mode. And last but not least, very valuable in my humble opinion, is the bipolar element. And this is huge because what this allows you to do is literally coagulate in the presence of body fluids, specifically blood, saliva, etc. So how important is this? Well, huge. I mean, I can't practice, honestly, without this particular element. In fact, the entire spectrum of this technology, if you're involved in any surgery whatsoever, I can't imagine that you would not want to have this type of technology at your fingertips. It's amazing how some folks do get along somehow, some way, doing even quote unquote minor surgery. I'm not sure what that means, but important to note that the clinical application of this technology specifically is zeroed in on this 4 megahertz wavelength, because it's equivalent to a quote unquote low temperature application, versus, as you see on the left hand side, high temp is traditional electrosurgery, which really is counterproductive to maintaining good tissue structure while we work. So need to appreciate this one important item. Now, looking at again, a brief overview of application for me. This is one where we get bleeding bone all the time, whether we're doing a sinus graft, any ridge augmentations, etc. You're going to have bone bleeds, and they're a nuisance, and some could be very problematic. If you catch a nice small little arterial, a nice little pumper, you can quickly, as you see here, I'm using suction at the same time, because with the unipolar element, it will not cauterize in the presence of body fluid. So we have to kind of keep suction at close by, but it works extremely well on bone, is what I'm saying. And periosteal release is huge. This application for me has been absolutely amazing, using this needle tip, one of many, many different tips, by the way, that Element does have. Great application, because here what I'm going to show you are 3 periosteal release techniques, and we'll begin with and matter of fact, you'll see the comparison of all 3, but we'll begin with the Element needle tip. And here's the posterior maxillary buccal flap that I'm releasing the periosteum with some slight brush strokes, as you see here, keeping in mind orientation of the flap, that we're not delving directly into the depth of the flap, but more of a lateral approach parallel to the alveolar process, so we don't buttonhole. And now we can use, of course, a nice sharp 15 blade. But when you start playing with the needle tip, you're not going to really want to use the blade at all, to be quite honest, nor do you want to use the scissors, although this is another form of sharp dissection and periosteal release, so we can passivate our flaps very nicely with these 3 techniques, of course. And once we've done sharp dissection, we can then apply blunt dissection in the form of a curved hemostat, as you see here, spreading, in this case, buccinator muscle fibers. And then this will be followed by the application of wet gauze and finger pressure, as you're seeing right now. So sharp dissection, 3 different ways to do it. Once you're comfortable with the needle tip, I will tell you, you will not want to play with either scissors or the blade. There's no need for that, because the incisions are so nice and clean, and you're getting some cauterization at the same time. So no problem whatsoever. Now here's just another quick example of periosteal release and flap passivation using that needle point. It is just so, on a cutting mode, by the way, it's very, very effective. You can use cut coag as well. And either way, you'll get a better coagulation of your vasculature, as opposed to using a blade, certainly, or scissors, where there is no cauterization going on, of course, whatsoever. And here's again the curved hemostat, just separating muscle fibers, once again, to passivate the flap. Now, bipolar, I mentioned, no question, this is huge. Once again, we get some bleeders, especially a really good sized vessel, a good arterial that's just pumping away. We can very nicely isolate that bleeder with gauze blunt pressure to start, and then get right in there with the bipolar unit, and this will cauterize again in the presence of blood, of body fluid. So it works extremely well, very, very effective, as you're seeing here. So great application. And again, if you took this away from me, I would feel rather naked in any surgical arena, for sure. So the final application, at least from a soft tissue perspective for me, that I'm sharing with you, is in terms of a vestibuloplasty mode. And this is one that's very, very impressive for lots of reasons, because not a lot of folks can appreciate, unless you really use the protocol, or the technology, if you will, with the protocol that I'll share with you now. And that is being able to create the entire recipient bed for receiving, in this case, an allograft, which I beg your pardon, yes, an allograft, which is alloderm or dermis, if you will, human dermis. So let's go through this video with you and just go through it step by step. This is an area where we have a lack of, and I'll just stop the video for a minute here. This is a lack of attached tissue. We see this in many places of the mouth, certainly many areas of the mouth, definitely following all of our cases where we're advancing flaps, as I just shared with you a little bit, periosteal releases, passivating the flap, advancing on the buccal. We're going to take many times good attached tissue and move it out of position. So because of that, we must have the use of some procedure to create attached tissues. Now, they don't have to be necessarily keratinized, meaning we don't have to use autogenous tissue, i.e. the pellet. In fact, since 1998, as I'll show you in just a bit with some slides, I've utilized this same protocol, meaning a vestibuloplasty using alloderm. Simple, very straightforward. Here we have to reposition our flap apically at least twice the length that we want in terms of the attachment ultimately. If we want 5-6 millimeters, we want to go 10-12 because there will be relapse. But with that said, it's very predictable. And I used the blade for many years until started to look at using the needle tip. And I was influenced strongly by Joe Niamtu. I give all the credit to Joe because of all the work he does on the face. I thought, well, geez, I can certainly use this in the mouth then for this application. Why not? It cuts with such precision as you see here. Again, just very light brush strokes. And again, making sure you're orienting yourself carefully. In this particular instance with the alveolar ridge dimension parallel to that, so you don't buttonhole through your flap. This is a split thickness dissection ultimately, meaning we're leaving only the periosteum on bone in order to receive, of course, the graft itself. So as you're seeing here, we're just very carefully, we began, by the way, at the mucogingival junction, and we're very carefully now just more or less brush strokes, using a brush stroke technique to cut through muscle fibers, the mentellus specifically, and getting right supraperiosteal. And then blunt dissection with gauze. We'll be able to pull our flap apically time to time. But this is just a real nice technique to work with, to use. I should say the technology is a great application of it for this technique and this protocol, because rather than use the blade, as you can see, we can very, very nicely separate our tissue layers very efficiently. Minimal heat dissipation, remember, that's a big one. That's a very big one. We're being very kind to the tissues here versus electrosurgery where there's a tremendous amount of heat generated. And as we get close to the bundle, I'll use more blunt dissection to identify where it's at and then work away from it with the same approach. Again, very light strokes. And we'll go all the way around the horn as you're seeing here. And I can, of course, even resect tissue very easily with this needle tip. And I'll do that time to time. And now we're just tacking down the apically repositioned flap. Here I'm using chromic suture. In the last probably couple years, I've changed into to using a glycolon, which is also resorbable on a large FS2 needle to be able to suture this down very well. So a series of interrupted sutures. And this is important to really anchor the flap margin to the base of your muscle. Very important to keep this immobile, and therefore the tissue bed now will be, when all is said and done, very pristine, meaning only periosteum is there. We can very nicely, again with the Elman needle tip, very nicely just separate what residual muscle fibers we have. So sort of cleaning up the recipient site well. And then at that point, in this case, we had some submerged implants. We can, rather I should say, if we had submerged, we can expose them at this point. And using that needle tip over, say, a cover screw is not a problem. And here I'm just filleting the tissue away with the needle, or I should say with the blade, We can do this with the needle tip as well. It's just to show you that there's to compare and contrast more or less, but you can do this entire procedure with radiosurgery. So here I'm just thinning out all this tissue, and at this point what we're going to do is place the abutments back into position, healing abutments, and now using the dermis, all we're doing is, as you're seeing here, creating some, like a little cookie cutter with the trephine, creating some openings. As I press the dermis against the abutments, I know where they're at, the imprint, so I can easily cut through there. And as you're seeing here, position the dermis kind of like a bib and begin to suture it. But what's real neat about this needle point technology is I can actually cut through this tissue, through the dermis, very easily versus trying to cut it with the scissors or with a blade. We can just nicely, as I'm going to show you right there, at any point we need to trim it, it's real simple, very straightforward. So now we use a smaller needle typically, as I'll show you for the dermis, and a smaller suture. This is typically a 4-0 on a P3 needle, and we're just suturing the dermis now in place. And again, I'm able to very nicely trim excess as I'm showing you there. And once that's in place, we let that heal for 3 months. At 3 months, you'll get about a 50% relapse, as I mentioned. But what's left is that band of about 5-6 millimeters that may not even look keratinized at the surface, but underneath it is. And most importantly, it's non-mobile. It's immobile tissue. That's what we're after. It's very, very, very predictable. I've been doing this since literally 1998. As you're seeing in this particular case, I've advanced. This was actually a sinus graft along with a ridge augmentation, and now we're ready for the soft tissue V-plasty that needs to be done to establish some good attachment and increase tissue thickness all at once. So Eloderm works beautifully here, and again, connective tissue side of this tissue has to be down. In other words, there's a basement membrane side, there's a connective tissue side. The connective tissue side must be towards the periosteum, certainly. So here you're seeing, again, just some nice examples of the V-plasty using acellular dermis matrix. And there's a 10-year follow-up here. We got some real nice creep, which will happen time to time, even as you would see with the free gingival graft, for example. So we had minimal attachment around these abutments. And yet here you see the increased thickness everywhere, and extended beyond what we started with. And again, a 10-year follow-up, as you're seeing here, tremendous keratinization on the surface. Again, we don't always get that, but it doesn't matter. It's just immobile tissue that we're after, as we all know, for these tissue-borne overdentures in particular. And then here's a 14-year follow-up as well. And in the maxilla, the same thing. We get the same basic results. So any of the V-plasties can be done with this particular protocol. The only negative here is that you don't want to have, if you have tremendous muscle pull, meaning a very severely atrophic mandible, that would be then a free gingival graft only. So just to summarize what we've covered in this brief time that we have together, some of the benefits of the Element 40 megahertz radiosurgery technology. As you see, we have very excellent coagulation. I mean, optimal, what I'll term optimal coagulation with minimal blood loss, and therefore your procedure is can be done more efficiently and with less time in general. Incisions are very precise with minimal pressure, as we talked about, just light brush strokes, if you will. And recovery of our patients, without a doubt, I think we're seeing some really nice results when I can compare sort of unscientifically using just a straight blade. I believe we are looking at less faster recovery and less pain in general, and minimum scar formation. So I think all of these items that we look at in terms of positive just pluses in general for using this technology are very good, without a doubt. But most importantly, just the fact that we can have the ability to not just coagulate bleeders, but to address our soft tissue work so well, and including, of course, bone bleeders, as I mentioned, with the unipolar element, but specifically being able to address tissue in general. What I didn't share with you are so many other items that I can look at with regard to application. When I remove tie mesh, for example, from my recipient site, full flap reflection, a lot of folks say, well, geez, if you use tie mesh, Mike, isn't that a pain in the whatever, trying to remove, separate your flap from the mesh itself? Well, no, not at all. In fact, in using the element tip, we just brush stroke across and it separates very easily. And the fact that we can glance across the mesh, as well as when we're exposing any implants that may be submerged, which is not real common, but when we have to, we can actually encircle the abutment itself by just lightly touching and removing the tissue. So in other words, light contact, intermittent, has no real effect on the metal itself, certainly on the implant, for example, or the tie mesh transmitting to the patient, et cetera, or any effect on tissue in general, versus, say, electrosurgery. That would be a whole different ball game. So again, in general, a wonderful technology for me, no doubt. Just a few comments with regard to the standard legal information that must come from all the companies, and this, of course, coming from Cynosure, which is the parent company of Elman. It's important that all of you study this, and you're going to get a question, a 10-question questionnaire. If you don't answer all 10 questions, you won't get credit. No, just kidding. This, again, is just a standard legal form that is important for disclosure purposes. And there are some upcoming webinars that I know Barb's going to comment on.
Yep. Hey, Dr. Picos, thank you so much. What a impactful session we just had with you there. Very, very amazing video presentation, and we really appreciate your knowledge you shared. Before we move on to our questions and answers, just want to tell our viewers we have two great webinars coming up on Thursday, May 28th. We have Dr. Christine Petty discussing some body contouring portfolio options for your practice. And then also on Friday, June 5th at 1 p.m. Eastern, we have Dr. Sethi, who will be really driving us down the road of the good, the bad, and the ugly of starting a new aesthetic practice. And it's a really good talk to have at this time. And let's move on. Let's get back to our topic for today. And Dr. Petty, again, that was just pretty incredible, very impactful RF technology demonstrations for us today. Thank you. Also, I want to mention Dr. Picos is having a course coming up on June 10th to the 13th. It's a 4-day course. If you're interested in attending, go to picosinstitute.com and check that out. So let's get started with our questions. Our first question here is going back to something that you did already discuss, but one of the physicians is asking for you to elaborate a bit more, if you don't mind, on the apolar versus the bipolar energy.
Sure. I can't give you the science behind it, but I will tell you that in using the bipolar technology, what we're able to do is to literally coagulate the bleeders, the vessels themselves, in the presence of fluids, body fluids, blood in particular. So a true dry field isn't necessary, and because of that, it's huge. I mean, in terms of application and clinical relevance for us, are you kidding? Because you can't use a unipolar or monopolar type cauterization there unless you have a really dry field. So a huge difference with regard to the clinical application. Can't quite give you the waveform difference. I don't know that offhand, but there's obviously a difference in terms of how the wavelengths are created and in what particular cycles to allow that to happen.
Okay, thank you. Thank you very much. Here's a question coming in. Can you review which modes you used for each procedure you spoke to today?
Sure. What I use probably the most is cut and cut coag with regard to when I use a needle tip for my flap passivation. because I found that that has been just so effective with regard to being able to literally separate tissue layers very efficiently, way better than a blade or scissors for sure. And in fact, I almost look at the blade and the scissors as being rather crude in comparison. So using the needle tip really has been a boon for so many years now. So that's cut and cut coag. When I'm using, of course, the ball, it's strictly coag for bone bleeds or even soft tissue bleeds. And then, of course, we've got the bipolar element, which is a separate attachment to the unit. And that is something that is, again, a little different rectified waveform, but invaluable for our use, certainly.
Okay, very good.
One
we'll
more point.
see.
Let me just make a point with regard to the mesh, because although I didn't show that, when I do expose the titanium mesh, there I'm using strictly cut coag, just brushing against the interface of the tissue with the metal, and I can very easily just separate the fibers away so nicely. The flap, it's just a very efficient way of doing that versus the older days for me when I used the blade.
Seems like such a delicate procedure, so it must be really nice. So someone is asking you a question about your emotions. Is it a stressful procedure? Are these procedures stressful for you? And do you find that using the RF technology sort of reduces that stress for you?
You just mean in general with any procedures? Well, I would say if in terms of stress, I think what's important to note is that if stress can be a result of many things, and one of them being just fear in general, and fear is basically the unknown. So I guess I could maybe go full circle with this and say, okay, so if you're just starting out using or doing any particular procedures in general, then you're going to have a fair amount of stress until you get comfortable with whatever procedure you're doing. Certainly, whether it's on the restorative end, prepping a tooth, all the way to, of course, all the surgical realm of what we do, i.e. dealing with bone and soft tissue, etc. So the long and short of it is, as you get more comfortable with a procedure, then there's less stress until things really become almost routine, but you're never without some stress. Now, that said, if you're going to apply this particular radiosurgery technology to what you're already familiar with using, say, blades and perhaps scissors, there's going to be some stress up front. I will tell you that, yes, because you're not going to be real sure what can be done with, say, a needle tip, and the fact that it's such a fine little tip, and it can cut very easily. It can separate tissue so fast with minimal, if any, pressure. So we have to be quite aware of your anatomy, of flap manipulation, orientation of your needle. I mean, a number of things have to be looked at, but like anything else, there's a weaning process. You've got to crawl before you walk before you run, etc., as we all know. So what I'm saying, I guess, is that stress is always there. It's a good thing. I have stress even after almost 37 years of practice. Any particular procedure I'm doing, there's always a bit of that. And that's important, because I think if you really feel so confident with any procedure you're doing that you kind of let your guard down, that's when things happen. Even with those of us who've done hundreds or even thousands of procedures over time, Murphy's Law is alive and well. So I can leave it at that, I guess. But I guess what I'm trying to say, make a short story long, is that stress from using something new is going to be there. Using this technology, it will de-stress you over time. That's bottom line, because you will see how easy it is to work with soft tissue in general. And the applications, by the way, are numerous. I personally, since I limit my practice to implant-based surgical reconstruction, I don't deal with a myriad of items that my partners and associates do, and that a lot of you do in terms of, say, just pathology in general, removing fibromas, doing gingivectomies, etc. So basically what I'm saying is that for the most part, there are many applications that I didn't even begin to address. And therefore, and I know that Joe Niamtu didn't either, because he's basically working on the face. I'm working specifically with implant-based surgical reconstruction. In between, there are a number of applications intraorally that this particular technology has for you to use, and therefore you can de-stress yourself knowing that the application is so smooth and so efficient and so predictable once you've mastered it.
Mm-hmm. Yeah, I could see where that would be the case. I mean, those videos really demonstrated how beautifully and smooth everything goes. So I have someone asking about dental lasers, and we know, I think you mentioned that that you're not working with dental lasers, but from your experiences or from your associates' experiences, can you compare the capabilities of RF to those of dental lasers?
Well, again, yes, I'm not, I do not use lasers at this point, at least in my career. I'm going to be looking at some to apply sort of sparingly myself. But again, with both of my kids on board as periodontists, they're getting involved with laser technology. So like it or not, I'm going to be at least aware of what's going on more, if you will, and see what application it would have for me personally with my work. But in general, those who have used lasers as well as the radiosurgery, there are different applications for each, certainly. For example, like the LANAP procedure and those sorts of things are done strictly with lasers that the radiosurgery would not have application for. But that said, there are a number of procedures where there's more or less overlap. For example, removing a lot of pathology that one can make an argument for or against either of the technologies. And I'm not so sure there's an argument against either. It's more or less what's one more comfortable with, etc. So there's certainly a lot of overlap. Depending on the type of laser, certainly there's so many different types with regard to specific, soft tissue only, bone and soft tissue, etc. So that's just a discussion in of itself. But I'm not the person of authority to really talk to any depth on that line.
Mm-hmm. When, Doctor, one of the questions coming in here is from a physician who's new and considering bringing in RF. Do you have a specific recommendation for mentorships or how they would go about practicing the use of the RF technology?
Well, with regard to using it, say, early on, there definitely are a number of courses that are out there that actually have as part of, I don't know that there's a single course in and of itself that devotes its time only to this topic, but within the realm of the different courses that are being offered, again, all over the world for that matter, you will find that there are sections of, say, a given course that specifically address how to use the technology in and of itself. There are a number of video tutorials that I know can be had as well online. In our courses, we offer, in our soft tissue course, we cover that in quite a bit of detail. We also address it in our bone courses because bone and soft tissue are so interrelated, of course, and the whole topic of our concept of a hybrid surgeon that we have talked about for a number of years, and it's at the heart of our institute, because knowing bone and soft tissue well in terms of handling, grafting techniques, etc., are critical to know those skill sets and develop them equally well to be able to do one as well as the other. You can't just do bone grafting without addressing soft tissue in detail. And so therefore, the use, again, of this radiosurgery technology is applicable to such a large spectrum of what we do in implant-based surgical reconstruction alone, let alone pathology and other realms of in periodontal surgery, etc. So again, to make a short story long, I don't know of one particular course that would deal specifically with radiosurgery per se, but a number of them out there will incorporate to some degree a section on it. And then it's just a matter of practicing, and even at the demos that we're all familiar with in our local rep. By the way, I want to give special thanks to Bill Bernstein, who's been so great to work with over the years as the head of at the realm of Helmo, I should say, of Elman Technology, and Ivy Garrido, who's our rep that we've had for a number of years. She's amazing. as a rep, she will take young new clinicians through those series of procedures just based on steak, just a piece of raw meat, and be able to actually get a feel for the use of the needles, for example, and the different tips. There are so many tips to be had for resective elements, for just incising, etc., for cauterization. So one can use, can do that as well, and just practice with literally tissue, even pig jaws, etc. So many ways to kind of get started, and then it's just again repetition.
Yeah, it is pretty amazing. I've had an opportunity to sit in on a couple of those demonstrations and use some of the equipment myself, and it is pretty cool. And I can imagine as a physician, as a surgeon, it would just be really like an art, and be able to create and just really be precise with your movements and the procedures you're doing. It's pretty cool. I've seen the physicians get a hold of these demos and just not want to stop and just use up 2 or 3 steaks in practicing. So it's not only informative, but it's fun. And you're right, IV is pretty incredible with that technology. So are you saying your clinical support has been good from Elman?
Excellent. In fact, that was one of my points is in my summary slide, that really the supportive element has been just tremendous over the years. Cannot say enough about that. I think it's huge to be able to have that available. Not always true for a number of things that we get involved with, technologies, etc. So that I can say has been a real positive, yes.
Yeah, well, we really appreciate you saying that. That's a very, obviously you've been in the business a long time, and your endorsement is very organic and real, and we appreciate that. Thank you. So it looks like we're all out of time today. Before we close up, do you have any thing you'd like to say, Dr. Picos? Any summaries, or are you good? How are you feeling?
Well, I guess I could maybe wrap things up with one maybe set of comments here, and that is regarding the use of this technology. Honestly, if you took this from me, it's one of a few items that I would just literally force me into retirement. It's indispensable for any tissue surgery that we're doing. We get bleeds, from bone, from soft tissue. So just from a cauterization perspective, let alone being able to work with flap management, just indispensable technology. So a big plug for using, if not this technology, my goodness, some technology that's going to allow you to cauterize tissues, at least at a minimum. And there are individuals that do surgery, soft tissue in particular, and have no means of cauterization. It's amazing to me how that can happen. So at any rate, I would say from a safety perspective, from being able to treat your patients effectively, from many perspectives in terms of just patient care, overall comprehensive management of your patient alone, let alone some potential medical legal ramifications, you need to have some ability to certainly cauterize tissues and deal with them in general in a very physiologic mode. So all of this is fulfilled with this particular technology.
Those are some real strong words. Thank you very much, Dr. Picos. We thank you for your time today, and your expertise is invaluable. Folks on the attendee call here, if you are new to aesthetic medicine and you have any questions regarding what you've heard today, feel free to reach out to your Elman Cynosure rep or chat us here today. And also take a minute to fill out the survey that's at the end of the call here. We appreciate you spending your time with us this morning, Dr. Picos, and to our attendees, and look forward to having you on our next webinar. So go out there and have a great day, everyone. Thank you so much.
Thank you. Thank you.